Hi, uh, permit me to introduce myself as Dr. C.R. Srinivas, Professor of Dermatology. I have been in the teaching profession for the past 30 years and have had the benefit of guiding many PG students who have been more of teachers to me than my students. And today I'll be sharing something about the use of topical steroid, use and abuse of topical steroid. This talk is aimed basically at the persons who are entering dermatology at the very early stage and those who are already into the practice of dermatology. And also during this talk, it is both evidence based as well as experience based. There are certain things I'll be talking from my experience, and for certain things, of course, there is more than adequate evidence. And you all well know that topical steroid is one of the most important armamentarium in the hands of the dermatologist. And you all know that it is produced by the adrenal cortex. And steroids basically are of two types, the glucocorticoid type and the mineral corticoid. Today, I will not be touching about the mineral corticoid. We will be mostly sticking to the glucocorticoids. And for the steroids which we use, we have both systemic as well as topical. Systemic, of course, we have been using for ages, is one of the most important thing. And people here elsewhere who have read Google and various things are afraid of steroids. And when we say steroid, they ask, "Sir, can we use steroid? Is it safe?" To them, I say that steroid is like fire. It is like fire in the kitchen. If there is fire in the kitchen, food can be cooked, but it is the same fire that can be used to bring down a building. So it is a question of who handles it and how it is handled, and that is the most important aspect of learning. And today I'll be sharing my experience as to how to go about handling this wonderful molecule that is one of the greatest molecule we are having. This has, as I told you, it is one of the has contributed a lot, has made many of our tasks relatively easy, and it is available in various potencies. Some are more potent, some are less potent, and some are long lasting, some are short lasting, some penetrate faster, some penetrate slow, and each of these advantage or the property of the topical steroid and the vehicles that go with it all can be exploited to give the maximum and also minimize the side effects of the steroids. Its mechanism of action is steroids is not soluble in water, so it is brought by a protein molecule which comes and once it comes to the cell wall, near the cell wall, it dissociates itself. A steroid being lipophilic, it can enter the lipid wall of the cell, this thing, and it can go and it can attach itself to the receptors, steroid receptors. Once the it attaches it to the receptors, it can get activated, and then two things can happen. One, it can stay in the cytoplasm, and especially if there is inflammation. And if there is no inflammation, for non-inflammatory condition, no inflammation, it can enter into the nucleus, and into the nucleus it can go and bind to the DNA and produce newer protein, which brings about the various change. And that which stays in the cytoplasm has got basically through lipocortin, it prevents the production of prostaglandin from arachidonic acid, and mostly has got the anti-inflammatory action. So that is the most important thing. Topical steroid has got both anti-inflammatory as well as anti-proliferative action. So once again, to repeat the same thing, glucocorticoid receptor present in the cytoplasm. It is a heterodimeric complex, and it binds to the cytoplasm through the receptor and through the heat shock receptors. And once it enters the cytoplasm, inside the cytoplasm, it loses the heat shock receptors, and binds to the DNA one side, and the other side it does not bind to the DNA, it stays outside and brings about the changes which I have already explained. Now, this topical steroid, as I told you, it varies in potency, and there are various ways to test the potency. The most commonly used way to test the potency is by the human vasoconstrictor assay. Steroid, when applied to the skin, can cause vasoconstriction, which is seen as blanching, and that lack of blanching or the erythema or the lack of erythema can be measured, and that gives an index as to how potent the steroid is. Unfortunately, This blanching action of steroid is neither anti-inflammatory nor anti-proliferative. It is a totally unrelated action. And based on its efficacy on this unrelated action, the potency of steroid is classified. But however, fortunately, in practice, we find that those which come out more potent by this assay are more potent, and those which are less potent by this assay seem to be less potent. Then there are various other ways to do this, like modification VS, like anti-inflammatory potency is there, like from small block biopsy we can do. Then other complicated methods are there, like fibroblast assay. We don't do those things. But what I basically practice is the histamine prick test assay. So this is a very simple thing to perform. What we need to do is we have to apply the steroids on the forearm and then put histamine over there and prick. And of course, without steroid, we put the histamine and then we see the amount of suppression that occurs because of the steroid. More potent the steroid is, the better it will suppress. Less potent the steroid is, the less it will suppress. And based on this, we can find out how effective the steroid is. Personally, in my opinion, this assay is a far better assay than the human constrictor assay, because here at least the mast cells are activated, histamine is liberated, there is some amount of inflammation, and we are studying the effect of steroid on these qualities rather than just the vasoconstrictor assay. Unfortunately, the steroids have not been categorized with this assay, and that study needs to be undertaken. This vasoconstriction assay, or sorry, this urticarial suppression assay or histamine wheel assay was basically designed by or used by Professor Gurmohan Singh and his student Dr. B.S.N. Reddy. Professor Gurmohan Singh was the professor of the Banaras Hindu University, one of the leading university, and has guided many other dermatologists in our country. And one of the luminaries he guided was Professor B.S.N. Reddy, who worked with him on these studies. And a colleague of V.S.N. Reddy was Dr. R.P.C. Nayak, with whom I had the pleasure of working at Manipal. And he used to speak to me about this assay. However, I did not, he told this to me about nearly 35 years ago. But it took me nearly about 20 years to actually put it into access when we had given it as a thesis to one of the students, Bharat Chavda, I think, one of the students who standardized this procedure at PSG at Coimbatore. So classification of this thing, there are steroids according to potency. We have the British classification and we have the American classification. British classification is relatively easier to remember, very potent, moderate, and mild. And of course, American has got 7. This is easier to remember, but then there is a wide gap. It does not cover the entire spectrum of it. There is for example, you'll find that betamethasone is much more potent than mometazone, triamcinolone, but these have been bracketed together. The American was more specific, wherein each steroid, topical steroid, finds its own slot in terms of potency. And in case you're interested in finding out, you can always go to that list over here. This huge list is there. With this, we can hold the steroids, see where the potency belongs, and based on that, we know how potent it is. Then what are the indications? These are the indications for systemic steroids. You know that it has got plenty of investigations, indications in dermatology, and we can use it, but it has to be used carefully. It has to be used properly. It like one should think twice about starting it, and then of course stopping it also is a risky proposition. And there are various ways to stop the steroids, which I'll be discussing as we go along. The indications of topical steroid are also many. I have just placed some, like psoriasis, vitiligo, lichen planus, dermatitis, alopecia areata, lichen sclerosis atrophic, morphia, discoid lupus. There's a huge list in there. But one thing which not many will know that is the topical steroids can also be used in a very smart way to withdraw the person from systemic steroids. And in the due course of my talk, I will tell you how it can be practically done. Then, of course, just as anything else, the vehicle is very, very important. And the vehicle is the one that is going to determine, to considerable extent, the potency. Like ointments are much more potent because they are occlusive. What happens is when we apply in the ointment, there is sweating does not occur, or sweating occurs, but evaporation does not occur. And as evaporation does not occur, cooling does not occur. As cooling does not occur, there is vasodilatation over there. And as sweat does not evaporate, there is more hydration over there. And because there is more hydration over there, the steroids penetrate better. So that is the advantage of ointment, which is the reason why ointments are very, very effective. Then, of course, there are creams. Creams has got its own advantage and disadvantage. It spreads much more easily. It has got water content. But since there is water, there is always a possibility that bacteria may grow in it. So it will have antibacterials, it will have antioxidants, it will have preservatives. So a lot of things. It is a package deal. One goes for the creams. Then, of course, we have the newer formulations such as shampoos and foams, and I'll be touching upon them briefly. So this is about the ointment. It can penetrate, it can reach much deeper, but it can also cause maceration. Creams, as I told you, have got a good lubrication, so you can cover the same with a much larger area, but then sometimes preservatives can cause irritation, stinging, and rarely the preservatives such as chrysols, parabens can cause allergic contact dermatitis. If you go on applying steroids, the person improves, and because of the allergic contact dermatitis, the condition worsens, and we got to keep our eyes open for that. Gels, of course, are non-greasy, can be applied over the hairy area, and lotions are much thinner, they spread over large areas. Then, of course, newer formulation foams are there. Under pressure, it can be, again, this can be applied over the hairy area, can be applied over large areas. And then there are shampoos. I have a reservation about the shampoo because shampoo is a wash off product. You apply it over there, wash off. Where is the time for it to penetrate? But then studies say that it works. But practically, I think we have to find out by some of these assays, by either the vasoconstriction assay or the arterial wheel suppression assay, to find out that shampoos within that given short period of time is able to initiate the changes that is required for it to induce the pharmacological changes which we expect when we use it. Then which topical steroid to select? Like I always say that when people say, about steroid molecule, they say you pick up one molecule, you become very good at it, you know how it works and continue with that. I totally disagree with that viewpoint. The disease chooses the steroid molecule which is required. Let us just discuss on this for a few minutes before we go to the slides. There are certain steroids like prednisolone, which has got both mineral corticoid activity as well as glucocorticoid activity. So in Addison's disease or in conditions where there is a requirement of both, we use this combination. Then there are certain things like betamethasone, which has got a very good glucocorticoid activity, but no mineral corticoid activity. It has got a good anti-inflammatory activity, and it can act for a long time. So these are the advantages of the fluorinated molecules or the betamethasone-like molecules. So each steroid has got its own advantage and disadvantage, and based on what you are expecting it to do, you should change the molecule of steroid. And for the same person at different time, we should have the courage and the knowledge to change the molecule of the steroid. Here you can't change the horse in the middle of the street. And then, of course, it is a question of uh, which area you apply. The skin over the face, the skin over the eyelid, the skin over the scrotum is thin. So you apply steroids, which has got less potent steroids, because it is going to absorb, going to get absorbed easily and going to act. Here, if you use a potent one, the unwanted side effects of steroids are more likely to happen. Likewise, palms and soles, they are very thick skin. So here you will have to apply a more potent topical steroid, or over the back, you will have to apply a more potent topical steroid. Thus, the site determines as to what sort of potency of steroid you got to use, and to some extent, the frequency also. So this is what is happening. The forearm, the absorption is less. On the scalp, it is just 4%, whereas in the scrotum, there is 35%. There is 300 times more absorption over the eyelid than in the plantar skin. So thus, according to the area, because it depends on the barrier, the stratum corneum in the eyelid is very, very thin, and that determines the barrier. So steroids can enter very easily over there, whereas in other sites, it is difficult for it to enter, where the skin is much thicker. Then what frequency should we apply the steroid? Should we apply it once? Should we apply it twice? Should we apply it thrice? Can we apply it on alternate days? Can we apply it twice a week? Because at the end of the day, always we are attempting to find out how little we can use, how less frequently we can use, because that is the one that is going to make the patient more compliant with us. To find out this, of course, there are various studies which has been done elsewhere, and we had also done this to find out the frequency of steroids application, which we conducted a study on this using the arterial histamine wheel test. And we found out that once daily application of steroid is by far as effective as twice daily, and alternate days and twice a week is not as effective as once or twice daily. Thus, the best results are by once daily application of steroids. But that doesn't mean that the alternate day steroids or twice a week steroids doesn't act at all. There also it acts, but compared to this, the action is much less. This is okay. You can apply once on the hand, once on the face, but what about palms and soles? For palms and soles, where the skin is thicker, for especially in case of hyperkeratotic eczema or conditions like hand dermatitis, you'll have to apply it 4 to 5 times. The reason is one, the skin is thicker, the penetration is going to be poor, and hands are a busy lot. With this, we keep on doing something. We put it in our pocket, we run it over hair, then we take out the cell phone, we do open the door, do something. So the medicine hardly stays on the hand. And this is another reason as to why we should apply the topical steroid more frequently over the palms and soles as compared to the other areas. Then we thought, there is there some way, like pulse therapy is there, wherein you give something for a short time and then stop it and then try to get this thing. So we thought, is it possible that we can apply steroid for 1 hour and wash it away? Will it have the same effect as leaving it full overnight? So we conducted this study, and then for that we will have to know at what time it starts acting. So by various studies and by the review of literature, we found out that the maximum action is at the end of 3 hours. So we did this study wherein we applied steroid for 1 hour, half an hour, 1 hour, and various duration up to 3 hours, and we found that at 3 hours there is maximum action, but at the end of 1 hour it is not. So after 1 hour, so this is very important. As to why this is very important is that a person applies the topical steroid and immediately he puts on the dress, or he applies it over the buttocks and sits down. So when this is done, say he waits for half an hour. The penetration is, you are not given adequate time for the steroid to penetrate, and much of what we apply goes on to the clothing rather than to the body or the site which we are trying to target. Then, of course, this new steroid came into the market, halobetasol. How does it act? They said that it is more potent than clobetasol. So again, we did this. We tested halobetasol ointment, halobetasol cream, clobetasol ointment, clobetasol cream to compare. And what did we find? We found that the maximum wheel suppression at the end of 24 hours or 48 hours is with halobetasol. That is, the initial action with halobetasol onset is much faster. But over a period of time, the effectiveness of both is virtually the same. That means it starts acting faster, but at the end of the day, both of them reach the rope at the same time. Is this important? Is this important? This factor, though both are equally effective after 24 hours, the very fact that the drug does not stay, and if any drug, if it gets a shorter time to stay, and if it can act better at that duration, then that drug may act better. And that is the reason why halobetasol may be preferred, because it acts much faster than clobetasol. Then we thought, now we are applying steroids. Is there some way by which we can apply topical steroids over a large area? There are many conditions where we think that he requires systemic steroids, and we do not want to use systemic steroids in that case. Many cases of atopic dermatitis, you feel that this person requires systemic steroids. Then what you do? Wait, be a little patient, try a course of antibiotic, and then you find there is significant improvement. You find that there is. Thus, the requirement of systemic steroid comes down in some cases by just using antibiotic. Whereas immediately, if you had hurried and started, you would have given much higher doses. Patiently, you have tried to give some antibiotic, bring down the super antigens, the person improves, and the requirement of steroid comes down. Likewise, there are ways. Is there some way by which, when you look at a condition and you think that this person possibly requires systemic steroid, and is there some way by which I can avoid systemic steroid in this person? Dilution is the answer. So we diluted the steroid with emollient moisturizing creams of various dilutions, 1:1, 1:2, 1:3, 1:4 dilutions we found. And then we found that 1:1 dilution is nearly as effective as the regular steroid. And now again, a newer diluted molecule is going to enter the market shortly with more amount of depot action. But that's a different story. Then we found that 1:2, 1:3, 1:4 is less effective, but not ineffective. Thus, we can, and then if you are going to give a moisturizer and then apply topical steroid, you all well know that moisturizers have got topical steroid sparing action. So first we apply moisturizer all over the body and then we apply steroid. That is okay. If small areas are affected, you apply the moisturizer and then you apply the topical steroid. But if large areas are affected, where both topical steroid and moisturizer is acquired, it's a big pain to apply first the moisturizer and this. So in those cases, we can use this dilute steroid. So 1 in 4 dilution can be made, 1 in 2 dilutions can be made. So initially we can use 1 in 2 dilution, and then after some time when the person improves, you can make 1 in 4 dilution, and that you can make it a single application, then you can make it alternate application, and that way you can gradually withdraw the steroids. And then if you want to bring in slot in moisturizers, you can use moisturizers in the morning, you can use moisturizers in the evening or night, and during daytime or during the evening, you can apply this diluted one, which you can shift from day to alternate days. Thus, by using dilutions of topical steroid, you can, in many cases, avoid topical steroid, oral steroids. And if you have started systemic steroid and you do not want to use any immunosuppressives in those patients to withdraw the oral steroids, you can use the dilution of the topical steroids. Then what about children? Of course, there's increased absorption in there. You have to be careful. Another thing about the steroid is once you apply, there is a reservoir effect or the depot effect. The steroids after application also continues to act, which is why, say for example, if a fungal infection where steroids are being grossly misused in India as well as in many other conditions, after stopping steroid, people don't become symptomatic immediately. Or this steroid which is there, when we stop the topical steroid and then we give them the antifungal, we find that initially it doesn't act at all. That is because the fungus, the steroids are still continuing to act by depot action, by staying in the stratum corneum. And during that period, whatever treatment you give for antifungal will not be effective until the steroid reservoir effect stops acting. And in practice, after long time usage, it takes quite some time for this depot action to go. So these are the various permitted in children. Some are various are available in different countries. In India, we have some of them like clobetasol. We have we have fluticasone. We have aclomitasone, clobetasone. We have. So these are the various things which we have. Hydrocortisone we have. Unfortunately, we have only 1.1%. We require a higher concentration of that. 0.1% hydrocortisone cream is hardly having any great deal of effect on the Indian skin, but much preferred in other countries. But I do not think it has any systemic. It is as good as a placebo. Then how much steroid to apply? When a person comes, you tell them, like, we have this advertisement for toothpaste. What do they show in the advertisement? The person holds the brush, and then the person, a pretty girl with showing all the teeth, or a man with all the showing all the teeth, big smile. He starts at one end of the bristles and goes on applying a thick layer, long one, nearly 1.5 to 2 centimeter long, all over the brush, and then starts brushing. But if you ask a dentist, they will tell you a pea size is enough. Commercial people, they want to sell more, but the idea is how much is really required. So from that point of view, to educate the person, to minimize the side effect, we have to tell the person how much steroid he must use. And you all well know the Philnace method, wherein 2 hand areas is equal to 1 fingertip unit. So you tell them that, see, look, this is only this much, and so you, for 2 hands we require this much. Since only your lesions are this big, you require 1/4 of a unit. And also to explain this further, we tested a fist area. So then we found that 1 hand area is equal to 2 fist area. We did the measurements and all. So we tell them that the lesion is 1 fist size of lesion you have. So you require 1/4 of the fingertip unit is what you require for application. And this, how do you apply? You make small dots over. For example, patient has a multiple lesion. If he goes on taking the steroids and applying, then he is going to use a lot. But this is the quota he has. This is the total amount he has to apply. So that amount, we ask him to put it as small dots over the various areas where it is required, and then spread it. Like if you take it and spread it, eventually much more than what is required is likely to be used by the person. So these are the directions which we have to explain to the patients. Then of course, how much fingertip unit area for various, this is shown over here. And the person for applying a topical steroid all over the body twice daily will require about 280 grams of steroids. And each fingertip unit in the male is about 0.5 gram, and in the women is about 0.45, a little less, but body size also is less. So possibly that is enough. A guide, it is of course a rough guideline. And this is of course the two hand area by the Finlays, how much is required to cover the face, how much is required, like 7 is required for the front of the body, 7 is required for the back of the body if you want to paint the whole body with the ointment. Then how much steroid for how long? This is a question people ask, how much steroid for how long? Now this question does not have an answer, because the potency of steroid varies, the amount that is used varies, the area over which it varies. So there is no answer to this question, like how much steroid is safe for how long, after which you should stop the topical steroid. Then what are the side effects? Like patient asks me about side effect. I again tell them that any medicine which has got effect will have side effect. In other words, a medicine that does not have side effect is not going to have any effect. And this is a package deal which a person should accept while going in for any treatment. Be it this treatment, be it any treatment, this aspect of the possible side effect has to be explained to the patient. And steroids, topical steroids, especially the more potent one, if applied over a prolonged duration, does have its own side effects. Some of this is striae distensiae, which is the stretch mark which you see. But unfortunately, unlike the other stretch mark which we get, here there is inflammation over there, and there is laying of the new collagen, there is scar formation over there, which is why it does not go away. And unfortunately, we see it in the crural region in many places where the scar sets in. Cutaneous atrophy occurs, like steroid, I told you, acts on the DNA, and in DNA it has got two different action. One is hyperproliferative, and other, it can decrease the size of the epidermis. It can decrease the size of the keratinocyte. It can cause thinning of the epidermis. So this action also occurs. So there occurs thinning of the epidermis, and then what happens when the epidermis is thin? We can see it becomes more transparent. We can see what is beneath. And what is there beneath? The blood vessels are there beneath. And what happens to the blood vessels? It has got collagen. And here collagen synthesis is diminished. So the blood vessel wall becomes weak. The support collagen becomes weak. And because the supportive collagen becomes weak and the walls become weak, the blood vessels dilate. And when the blood vessels dilate, there is an erythema because of the more amount of blood flow into the vessels. This can be easily seen, and the vessels can be seen which appear as telangiectasia, and we go on doing this, go on applying over a period of time, tuck the vessels, give way, and the purpura, there is bleeding into the skin. And as I told you, when we apply topical steroid, there is blanching over there, and when you apply, withdraw the topical steroids, then there is vasodilatation over there, and this vasodilatation also can give rise to erythema. So on stopping, there can be erythema. On prolonged use, because of the permanent vasodilatation, there can be erythema. Then there is perioral dermatitis. Do not know exactly. It could be like something like seborrheic dermatitis like lesions, or it could be because of fungus. We do not know exactly what is the cause. It is an inflammatory condition, which is why possibly it responds to tetracycline group of drugs. Rosacea is another condition wherein because of thinning, atrophy, redness of the face occurs, and that gives rise to steroid-induced rosacea, which is relatively more amenable to treatment than the primary rosacea which occurs. Acne can be precipitated by steroids, can be treated with steroids. It suppresses the sebaceous gland, the amount of sebum secretion comes down. So when a person starts applying it initially, you'll find that there is a very significant improvement. But then over a period of time, there is shedding of the duct epidermis, and that goes and blocks the outlet, and that gives rise to more amount of acne. Rebound erythema, I told. And what happens if a person goes on applying this topical steroid over a period of time, over a long period of time, the skin becomes used to this topical steroid. It becomes, then when you stop it, the skin cries for the topical steroid. This occurs over the face and over the scrotum, the crural region, and we have got multiple names for this, like topical steroid damaged face, topical steroid dependent face, or some of the things. And milia can occur because of the scarring, and fungal infections can occur. I'll be coming more to the fungal infection. Scabies can become more. Candidiasis can become more. We know that the vellus hair, intermediate hair can become longer, giving rise to hypertrichosis. And what happens? There is thinning of the skin. And as there is thinning of the skin, there is less amount of melanin production. There is less amount of melanin production, and that is what is giving us protection. So those factors, the stratum corneum, which is thinned out, the melanin, which is there, which is going to offer protection, that factor has been removed. And the removal of these factors makes the person more sensitive to sunlight. And because of the decrease of the melanin pigment, and because of the destruction of some of the smaller melanin melanocytes as well as melanin, there occurs spotty depigmentation, which we get in this. And rarely, as I told you, there can be on stopping, there can be inflammation, and inflammation can lead to the hyperpigmentation. Then contact dermatitis. Topical steroids are supposed to be treated for contact dermatitis, but can it cause contact dermatitis? Yes, if diamond can get diamond, if fire can put out fire, topical steroids, which is supposed to douse the dermatitis, can also cause dermatitis. One can become sensitive to the molecules of the topical steroid itself or to the preservatives which are used. The common preservatives being parabens, crisols, and whatnot, a person can become sensitive to that, and one has to keep the mind open to that possibility, wherein you'll find that you'll go on applying topical steroid, there'll be slight improvement, but then very soon there'll be aggravation of the condition. Tachyphylaxis. Does it occur? Yes, you'll find it progressively as you go on applying. We could not demonstrate tachyphylaxis by the experimental assays. It could not be demonstrated, but practically we do find that as the person continues the topical steroid, it becomes less effect. So body demands more. So that happens everywhere. When a person goes on drinking alcohol, the demand for alcohol goes up. Anyway, anything that you do, for example, insulin, anything, as a person, the demand for that goes on increases. Likewise, the demand for the steroid goes on increases, and because the demand increases, the effectiveness comes down. To beat that effectiveness, one has to use a more potent topical steroid for it to, and more potent topical steroid is more side effect. Then what about the ocular side effect? It can cause glaucoma, it can cause posterior subcapsular cataract. And so we try to avoid topical steroid application over the face. Good enough, we don't apply because a person can develop glaucoma. But then there are certain conditions like chronic actinic dermatitis, which is a very person want to just scratch away the skin, pull away the skin, and even commit suicide. Such is the intensity of itching. So you have to give him relief, and no medicine apart from very high dose of oral steroid is going to give the itching. So we have to use topical steroid. So how can we use it? It is going to cause glaucoma. It is going to cause cataract. So consult your ophthalmologist friends. Find out if the person already has glaucoma, already has this thing. Then start the topical steroid for a short time. If required, measure the pressure. Just as we look at the blood pressure and give cyclosporin. Here we measure the pressure and give the topical steroid for these persons for a short time. And then of course try to wean it off by using the calcineurin inhibitors or the milder steroids. Then, of course, if applied over a large area for a long time, patient can develop Cushing's disease, which occurs more with systemic than with this thing. HPA axis suppression also can occur with the prolonged use. This is seen much more in children than in adults. So this is what I said. Can we apply potent topical steroid over the periorbital area? Yes, provided you do this. We conducted this study, but unfortunately we never got around to publishing this, wherein we monitored the topical steroid along with the ophthalmologist when the person was on, and we did not find that there was a very significant improvement, increase in the pressure within a period of 10 to 15 days when we use the topical steroid. So these are the adverse effects. Both systemic is shown on this side, the skin side effects, all of which I already discussed, each in detail, is there on the left side, systemic as well as topical. The same thing again, the various side effects, common adverse effects of steroids. Then when we apply, some of the time you'll find the persons will say there is burning, there is stinging, there is irritation, there is a swelling of the skin when it occurs. All that could be because of the vehicle. So when a person complains that he is having this issue with the topical steroid, then it is worthwhile looking at it to see what it has. Quite often, the answer to the side effect may be in the vehicle that is there in that molecule. Because nowadays we get it with lactic acid, wherein There is a hydrating factor. It's a emollient over there. So people do mix it. And we find that in some persons, this can cause smarting of the skin. So these are the side effects which you can see: telangiectasia, acne, acneiform eruption, hypertrichosis, erythema, pigmentation, hypopigmentation. Hypopigmentation is another very interesting thing. We find that this hypopigmentation of the topical steroid we see is more pronounced over the exposed areas than over the covered areas. The reason being that although it can cause over the covered areas, in fact, to test this hypothesis, I applied it over my own back for nearly about 15 to 20 days. There was no hypopigmentation. But then when you apply it over a lichen planus lesion or a lichen simplex chronicus lesion on the exposed part of the leg, you will find that the rim of hypopigmentation occurs along this. The possible reason is that the ointment itself is acting like a sunscreen over there, preventing, because of the hydration, the amount of sun does not tan that area, which could be. And because of the anti-inflammatory action over of the steroid, it prevents the pigment tanning that occurs following exposure to the UVA or B. So this is the uh, scars which we get, stretch marks, and here collagen gets laid, so it becomes a thick scar which is hardly amenable to treatment. And here you can see fungal infection, which is over there. Sometimes very difficult, and nowadays we see it covering the whole body. And this is the perioral dermatitis you can see. Erythema, sometimes we get pustules. Folliculitis can occur because of steroid. Folliculitis can occur because of the ointment in it. We can get Pitrosporum folliculitis, much more common over the back, sometimes difficult to distinguish from acne, Pitrosporum folliculitis over the back. Perioral dermatitis, erythema of the face. Steroid addiction, I already spoken to you briefly about it. Person gets used to it and they are not able to stop it. And these people, it is a very friendly neighbor. The friendly neighbor who gives it, or the friend who gives, I tell them that person is no friend of yours. And then I tell them, do not keep this, throw it away, because ointments are very peculiar thing. People, you prescribe something, people will go and leave it on the refrigerator, they will leave it by the shoe box, wherever it is. And whenever they have any problem, they will take it and apply it on the body. They will think that ointment, it is an ointment, it is not going to do anything, no harm. And they keep on applying the same thing. So people tend to misuse, abuse, and overuse the ointment, and they do not use it quite often the way we tell them, and they use it when it is not needed. So that is the problem with steroid. And as they go on using it, there occurs a steroid addiction, possibly due to increased serum nitric oxide levels. And you stop it, there is a flare. So here is a lady who wanted to become fair, who used the triple combination, which I don't like much. I very rarely use, but then very rarely I do. But then these persons with mometazone in it, or even more potent topical steroid, or just steroids itself, they apply it for fairness. And then they develop acne, they develop telangiectasia, they stop it, it becomes erythema, erythema subsides, they develop pigmentation, there is burning and stinging on the face, and then coming out of it. So you stop it, it is going to cause. And then here is a very, very important thing you have to tell the person. So you stop it and you give a moisturizing cream or you give some other cream. Patient will come and tell after about 20 days that they did not use the cream which you gave. And why they did not use? Because it caused more burning. And why was the burning there? Not because of your topical, but because of stopping the steroid. So when you're stopping the steroid and you're giving the topical, you must tell them that your symptoms are likely to aggravate. The molecule which I am giving is not going to act as well as the topical steroid, the potent topical steroid you have been using. But here is what this is, you have bought it. So now you'll have to put up with it. I will surely help you to get out of it, but it is going to take some time. In some cases, we do use tricyclic antidepressants in this case, and very, very rarely we tell them to use a milder topical steroid. It's a better idea to tell them, give them a topical steroid and tell them this molecule is like the one which you used, and I don't want you to use this much. You keep it under your pillow. If you have got a very severe problem, then take it out and put it. And once they have it over there, then they feel more comfortable. So this is the what happens. Initially, the lesions improve with the topical steroid, and continuous use. There is a immunosuppression, there is microbial growth, there is inflammation over there, and there is redness over there. On stopping, there is rebound flare, and the red burning skin syndrome appears. Rebound phenomena on the red skin. And see how it improves after stopping. And this is what in the TSDF we call it as a topical steroid dependent phase or topical steroid. Much more complex, not only for face, topical steroids are grossly being misused in India because of the fungal infection, which has become so rampant and so difficult to treat the fungal infection. All the family members will be using this quadriderm and various such combination, panderm, various such combinations. They'll be going to the friendly neighborhood shop, the corner shop, who gives them one, and they will apply it for 2-3 days. They will have relief for 4-5 days. Again, they will apply for 2-3 days, relief for 4-5 days, and this continues for years before they land up with us. And we conducted this study. It was an excellent study. We had an ACAD, which was an E group, and the initial stages, the E groups were very active in the social media, and this study was generated in the ACAD in the social media, wherein the two things in India were born from the social media. One is a journal known as the IDOS journal, the brainchild of Dr. Gopinath, who is no more. And second is the study wherein all of us who were interested in topical steroid, we went on talking of it. Then we said it is time to stop talking and start acting. And that act resulted in the publication of this article. And here are some more pictures. And this is what happens. Long-term steroid, there can be axis suppression, more seen in cases. I have seen children with psoriasis or even adults who apply one tube of 20 or 25 grams of topical steroid per day. So they apply it all over the body. So it is but natural that they are going to have that thing. And the withdrawal symptoms also will be there. The behavior is likely to change. There is likely to be steroid psychosis in them. So these are the various other things which one has to consider in these patients. So, what are the factors responsible for this axis suppression following topical? Using a more potent one, increasing the, and then in case of atopic, where the barrier is not there, you use a potent one all over the body for a long time, then you are likely to develop this HPA axis suppression. But fortunately, it does not seem so common in atopic dermatitis. I don't know why. Probably because they got a hyperactivity, they tend to metabolize. I don't know. The side effects because of this seems to be much less than in case of psoriasis, where they apply and you find the really Cushingoid feature, pustular psoriasis. Sometimes on stopping the topical steroid, the pustular psoriasis, withdrawal of the topical steroid can give rise to pustular psoriasis. Then applying steroids over a wet wrapping also can enhance the absorption, can cause the axis suppression. So I have been talking to you about topical steroids. Topical steroids are one of the mainstay. There are various ways to minimize the use of topical steroids. One I told you is by diluting it, using the right molecule for the right place, for the correct duration, and then trying to see if we can give windows between the application from daily application to alternate days application, increasing use of moisturizers in these persons to, and then giving it in such a way that the person cannot go and buy it over the counter. This is what I call as getting the maximum out of minimum. We cannot do without topical steroid, but let us do with it in a smarter way. Thank you.